Imagine a cancer treatment that works. I mean, really works. Until one day, it just stops. For a lot of patients with advanced thyroid cancer, that's not a hypothetical, it's a harsh reality. But what if you could reach inside those cancer cells and flip a genetic switch, basically forcing them to listen to the treatment again? Well, today we're going to dive into exactly that, a groundbreaking strategy called redifferentiation therapy.
So here's how we'll break it down. First, we'll get a handle on the problem itself, this treatment-resistant cancer. Then, we'll look at how scientists are unlocking its genetic code to fight back. After that, we'll walk through the actual treatment process, decode the really promising but also kind of complicated results, and we'll finish up by looking at the big questions that are still out there.
Okay, so let's set the stage here. For decades, the go-to treatment for thyroid cancer that has spread has been radioactive iodine. And it's brilliant, really, because thyroid cells, even the cancerous ones, are hardwired to suck up iodine. But then the cancer evolves, and it hits a wall.
And that wall has a name, radioactive iodine refractory thyroid cancer, or RAIR for short. Essentially, the cancer cells get amnesia. They forget their thyroid cells. They shut down the very molecular doorway that lets iodine in, and if the radioactive iodine can't get in, well, it can't do its job of destroying the cell. The treatment is effectively locked out.
And listen, this isn't some rare fringe problem. The numbers are pretty staggering. About 2/3, that's right, 2 out of every 3 patients with metastatic thyroid cancer will eventually see their disease become refractory. And that leaves them with far fewer and often much tougher treatment options.
So you have to ask why. Why does this happen? Well, the answer is written in the cancer's DNA. Researchers figured out that very specific genetic mutations are the culprits. These mutations basically hijack a critical communication highway inside the cell. It's called the MAPK pathway. And when this pathway gets stuck in the on position, it just starts firing off all the wrong signals, telling the cell to slam the door on iodine.
But here's where it gets really clever. Once scientists identified that exact genetic lock, they realized, hey, maybe we can craft a genetic key. This completely changes the game. We're not just attacking the cancer anymore. We're trying to outsmart it on a molecular level.
And that key strategy is called redifferentiation. Such an elegant idea. Instead of searching for some brand new weapon to kill the cancer, the goal is to use these highly specific targeted drugs to temporarily re-educate the cells. Remind them of their roots. For just a short time, you make them act like proper thyroid cells again, reopening that critical doorway so the radioactive iodine can finally get in and do what it's supposed to do.
And this is why getting specific about the genetics is so important. You see, there are 2 main culprits. On one side, you've got the BRAF V600E mutation. Think of this like a gas pedal that's just stuck to the floor. It forces that MAPK pathway into overdrive, and that aggressively shuts down the gene that makes the iodine doorway, a gene called NIS. On the other side, you've got RAS mutations. It's a different switch, but on the same pathway, and it causes a very similar problem. This is exactly why genomic profiling of a tumor is absolutely non-negotiable. You have to know which switch is broken to pick the right tool for the job.
And here are those tools, the molecular keys. These drugs are all MAPK inhibitors, and they're incredibly precise. Some, like vemurafenib and dabrafenib, are BRAF inhibitors. They're designed specifically for that stuck gas pedal mutation. Others, like selumetinib and tramitinib, are MEK inhibitors, hitting a different spot on that same pathway. And sometimes you even use them together, in combination, to block the pathway from a couple of different angles. All right, so we get the what and the why. But how does this actually work for a patient sitting in a clinic? Let's just walk through the process, step by step.
It's basically a 4-step sequence. First things first, screening. Patients get their tumors genetically tested to see if they even have one of these targetable mutations. They also get baseline scans to see exactly where the cancer is and how big it is. Step 2, they start a short course. We're talking just 3 to 6 weeks of a targeted drug. Step 3, while they're still on that drug, they get the standard dose of radioactive iodine. And finally, Step 4, follow-up scans to see if that 1-2 punch actually worked.
And this diagram here, this is pretty much the playbook that researchers follow in these clinical trials. What you need to see here is that the targeted drug isn't meant to be a long-term treatment. It's a short, sharp intervention. It's a primer, really. Its only job is to get the stage ready for the old therapy, radioactive iodine, to work again. It's a very carefully choreographed dance.
Okay, so we get to the big question. Does it actually work? And this is where we get into the trial results, which, well, They paint a picture that is incredibly promising, but also really complex.
I mean, just look at this chart. The results are kind of all over the place. That first bar shows that the drugs were able to restore iodine uptake in anywhere from 33% to a whopping 95% of patients depending on the trial. But, and this is a big but, look at the second bar. Just because the cells can absorb iodine again doesn't automatically mean the tumors shrink. The actual tumor response rate swung wildly, from a pretty modest 11% all the way up to an incredible 80%. And that variability? That's the huge puzzle researchers are trying to piece together right now.
Now, this table gets us a lot closer to figuring out that puzzle. It breaks things down by the specific mutation and the specific drug. And wow, look at this. For cancers with that BRAF V600E mutation, combining dabrafenib and trametinib led to a 57% partial response rate. But for RAS-mutated cancers, a totally different drug, selumetinib, was the clear winner, hitting an 80% response rate. This just screams precision matters. One size does not fit all, not even close.
And this, right here, is what success can look like. This is a real patient. On the left, you see a CT scan of lungs just filled with metastatic cancer nodules. But on the right, 6 months after this therapy, the disease is stable. It's still there, it hasn't vanished, but its aggressive forward march has been stopped in its tracks. And for a patient whose cancer was otherwise growing out of control, stable disease is a huge, huge victory.
Of course, no treatment comes without a cost. There are side effects. This chart shows that, yeah, over 80% of patients have some kind of adverse event, like fatigue or a skin rash. But the really serious grade 3 or 4 events are much less common. And the key advantage here is that because the drug course is so short, these side effects are temporary. They pop up, and then they go away after the treatment stops.
So let's just land the plane here on this point. Redifferentiation is a powerful new tool. It can give significant tumor control to patients who were running out of options. But, and we have to be really clear about this, it is not a cure. Across all of these studies, only one single patient has ever had a complete response, meaning the cancer completely disappeared. This is a palliative therapy. It's a new line of defense to manage the disease, not eradicate it.
Which brings us to our final section. With these exciting but also very mixed results, what are the big unanswered questions that are going to drive the future of this therapy?
Really, the focus now is all about refinement. Researchers are asking these super important questions. Can we get better at picking the ideal patients? What's the perfect drug, the perfect dose, and the perfect timing? And this one's a big one. How much of this effect is actually from the reactivated iodine versus just the targeted drug itself? The ultimate goal is to move this from something that works great for some patients to something we can predictably make work for most patients, to turn it from an art into a science.
And this quote from the International Thyroid Oncology Group really puts it all into perspective. They're basically saying, look, this is exciting, but the level of hard evidence is still low. We don't have those gold standard randomized trials to prove, without a doubt, that this strategy helps patients live longer or better. It's a reality check and a call to action for more rigorous research.
And that leaves us with this final, really fascinating question. Is this therapy just a bridge, a way to buy patients more time until the next big breakthrough comes along? Or is it something more profound? A fundamental shift that turns a deadly, aggressive cancer into a manageable chronic disease. The truth is, we don't have the answer yet. But for the very first time, thanks to our ability to read the cancer's own genetic playbook, it's a question we can finally seriously ask.